So we would start the first long case. It's by Dr. Vasav Somani.
8-year-old male. My patient is an 8-year-old male, playful child, resident of Vid, Hindu religion, informing being the father, presented to us with the chief complaints of difficulty in walking and difficulty in sitting cross-legged since 8 months. The patient was apparently all right around 8 months ago, following which he started develop difficulty in walking, which was insidious onset, gradually progressive, unassisted, which was occasionally associated with pain on prolonged activities and relieved on rest. And it was first noticed by father, following which he was taken to a local practitioner where some radiographic investigations were done and he was advised some conservative medications and rest. The patient took the conservative medication but did not follow the advice to take rest. Hence, after a period of around 2 months, his symptoms started aggravating and started experiencing difficulty in sitting cross-legged, which was occasionally associated with knee pain and left-sided groin pain. For which again father took him to a Ayurvedic doctor where some local applications and medications were given and massage was done for around 2 months. And then father noticed that his complaint, he felt that the complaints were resolving partially. So he didn't took any treatment for 4 months around. Then like around 10 days ago, one of his relatives referred him to a KM hospital and he presented to us with difficulty in walking, which was not associated with pain at present and has difficulty in sitting cross-legged. The patient is a second-born child out of a non-consanguineous marriage, which was full-term, normal vaginal delivery with normal antenatal, intratem, postnatal, without any complication, with no NICU admission, with a weight of 2.5 kg. And currently the child is having normal motor developmental milestone with good social skill, verbal skill, and good scholastic performance. There is no history of trauma, no history of steroid intake, no history of blood transfusion, no history of any bleeding disorder. There is no family history of the similar complaints. There is no history of prior hospitalization. There is no history of morning stiffness. There is no history of any other joint involvement.
So why not septic hip? Sequelae.
Sequelae, but ma'am, he doesn't have any prior complaints in the.
Told me he's 2.5 kilos.
2.5
birth
kg.
details.
He did not have any history of.
Is that normal birth weight for Indian child?
2.5 kg.
Or is it slightly lower than the average?
I think 2.5 kg is the baseline, below which we categorize them as low birth weight.
Yeah, but you're saying he's staying in some region and then 2.5 birth weight. 8 months sequelae. How much do you believe the history of the father? So, point of the whole thing is, when you know your cases, Perthes, don't go too much into non-consanguineous marriage, 2.5 kilo birth weight. It's not relevant to this case. Na?
Okay.
Yeah, that's the only reason I was asking. I have no interest in taking a neonatology exam at the moment. But would you want to give a lead diagnosis or do you want to go into a DD?
Ma'am, I'll give a
Before that, regarding the pain, a few points that I would like you to emphasize is, was this pain, was it associated with recurrent exacerbations and remissions, or was it a continuous pain? Was there a progressive deterioration in the, pain and length? And was there a history of night cries? I'm not sure whether you mentioned that.
I forgot to mention that. Sir, actually, the patient developed a painless limb. And occasionally he developed complaints of pain after a period of prolonged playful activities. Otherwise, he never had complaint of pain. And after a period of when he started taking medication for the first time, he didn't stop his activities. So he developed pain over a prolonged period of time, which was occasionally associated with knee pain. But otherwise, there was no specific complaint of pain as such.
So how is this history important? I mean, if you say that the pain is continuous and it is progressively deteriorating, would your DD change as compared to a pain which has recurrent exacerbations and remissions, which is mild and not interfering with his day-to-day activities?
So can you repeat?
How would your DD be different? Or your list of DDs, the order of DDs that you give, would it be different if your pain is continuous and deteriorating associated with night cries versus pain which shows exacerbations and remissions and not associated with significant limitation of day-to-day activities?
Sir, I would like to keep, if the patient has complaints of night cries, I would like to keep TB as a differential. Although here, since the patient is coming from a lower socioeconomic class and considering the age, I would like to keep TB as a differential also.
The only thing I would say is that, you have had a very good description of your history taking. That's really very good. But remember that when it comes to lower limb problems, we are looking at mainly three things: pain, limb, deformity. They are the three commonest things. And each of them, you should quantify them further in terms of onset, duration, progress. So the key symptoms are something that we must expand more on. So the rest of the stuff is all negative history, which is all good for completion's sake. I think that's important, and you have done a good job with it. But the main complaints are something that we must elaborate a little more on when it comes to lower limb. So pain, limb, deformity, they may not have all three. They may have one or two or all of them. Each of them onset, duration, progress, because it makes a very big difference to us if there's something you say that the pain is occasional, is once in a while, very different from unrelenting pain throughout the day, even at night. So you must describe that pain. What causes it to aggravate? What are the remission factors? What are the exacerbating factors for that pain? Okay. Same way for limb, same for deformity. We want to know progression. Is it progressively getting worse? Is it getting better? Because so many of our etiologies, we know in pediatrics especially, get better with time. So not just necessarily getting worse. Getting better also is important to us. So when it comes to deformity, it's the same thing. You have genovarum, genovalgums, which over time get better. Then we know that it's not pathological. So that's the only thing I would add to your history taking, is that a little more on the presenting complaint. Before you go into all the negative history, which was good, talk a little bit about onset, duration, progress for each of those presenting.
Actually, the patient never had a significant complaint of pain. He started facing difficulty in walking. There was no pain as such. Occasionally, when the second time when he didn't stop his activities, like around after 2-3 months, he started feeling occasional left-sided joint pain. Otherwise, there was no such significant pain. So, moreover, it was a painless walking or a limb that I would like to describe.
So don't harp on the unnecessary stuff. When you're writing your presentation down, remember this, that what you want to showcase to the examiner is what are the most important things and everything about those important things, because all the decision making is going to be based on that. So do you want to rework in like one sentence, just present now as if this was a short case? What do you want us to focus on?
This is an 8-year-old male playful child presented to us with the chief complaints of difficulty in walking and difficulty in sitting cross-leg of 8 months duration, which was occasionally associated with pain and not associated with fever and evening night cries or anything. So I would like to keep my differentials as tuberculosis. Then
so lead differential always should be what you are going to be able to maximally defend.
Okay, I would like to keep Perthe as my differential, tuberculosis, and developmental coxa vara maybe.
How would developmental coxa vara differ from this?
Ma'am, the initial presentation of history more or less will be same. Patient will have pain, as considering his child, this child has more or less painless walking with occasionally associated with complaints of pain, and the also developmental coxa vara will moreover develop when the child starts to walk or at the same age.
Good. Let's examination.
I examined my patient in broad daylight in sitting, standing in supine position from front, side and back. My patient is well oriented to time, place and person. On general examination, there is no anemia, pallor, icterus, clubbing cyanosis. There is subcentrimetric lymphadenopathy, which are normally palpable in children. And on examination, the child has an erect posture with normal lumbar lordosis, with the ASIs at the both the ASIs at the similar level, with the left-sided knee and ankle at a slightly higher, appears to be at a higher level. There is appears to be muscle wasting with no visible fullness in the star bar triangle, and there is no scar swelling and sinuses. On examination from side, the left-sided trochanter appears to be at a higher level, and the PSIs appears to be at a similar level. I'd like to confirm my inspectory findings on palpation. The patient has no local warmth, no local tenderness, no superficial tenderness, no local tenderness. There is no tenderness over the superficial or deep tenderness over the greater trochanter. The greater trochanter appears normal in contour, and the femoral pulses are bilaterally palpable, which are equal in force, volume, and distribution. And, on movements, the patient has a flexion range on the left side, which is 0 to 130 degree, which is same on both the sides. The patient has rotation of abduction and internal rotation, and flexion range is 0 to 130 degree on both the sides, with the abduction range of 20 degree on the left side and abduction range of 45 degree on the opposite side, which is pain, not associated with pain. The adduction range is same on both the sides, which is 20 degrees, and the rotations which are measured in flexion and extension. In flexion on the left side, the internal rotation is 20 degree. On extension, it is on flexion it is 10 degree, and on extension it is 20 degree, and the external rotation is 30 degree on flexion and 40 degree on extension, as compared to the opposite side, which is 40 degree of external rotation and 20 degree of internal rotation. And all the moments on measurements, there is a wasting of around 3 centimeter on the left thigh region, and the apparent limb length is there is the true length difference is 1 centimeter, and also the apparent length difference is 1 centimeter. So overall, the true shortening is 1 centimeter. The shortening were further confirmed with the branch triangle, which also showed there is 1 centimeter of supratrochanteric shortening, and also confirmed by Nilaton's line and Shoemaker's line. On performing special test, the Trendelenburg sign is positive, and Galeazzi test is positive.
What do you mean by Trendelenburg? What do you mean by Trendelenburg sign being positive?
So Trendelenburg sign being positive is the patient, while asking him to stand on the normal leg, the opposite ASIs is at a higher level. ASIs and PSIs are at higher level, which suggests that the leg on which he is standing has a functional abductor. But while asking him to stand on the affected leg, the ASIs and PSIs appears to be at a same level or a slightly lower level in this patient. I could not appreciate, but it is at the same level. But the child is also not able to stand for a prolonged duration. But while
Trendelenburg will not do the levels of anything. It is what is happening with the pelvis when you stand. So what exactly is happening with the pelvis? By talking of anterior superior iliac spine, posterior superior iliac spine, we're not looking at levels of anything. We're looking to see what's happening to the actual pelvis. So what does the Trendelenburg sign mean? That there's a drop in the pelvis, which is sudden and steep of the affected, or when you stand on the affected limb.
Can you show each of your findings?
No, let's finish it. Let's have you finish with all your...
Then yes, more or less.
Okay, you're not mentioned about other joints.
So the SI joint is normal. The same side knee, ankle, and the opposite side hip, knee, and ankle are normal without any tenderness or restriction of range of motion, sir. And the patient has nil distal neurovascular deficit.
Anything you want to add on general examination?
Is the abduction different in extension versus flexion of the hip?
Actually, check.
I think on this side better.
Yeah, because
they
the
have a lot
camera
of-
is filming it, and they won't see it.
I'd like to stabilize the pelvis, keep my both hands, and I'll check for the range of motion abduction, and I'll move till the pelvis starts moving. Now here the pelvis starts moving on extension. And should I go with flexion? Okay.
Talking hip in hip flexion. So in hip extension, hip flexion, not knee. We understand hip flexion.
See the sir?
It's a hip condition, no? So we want to see the hip in flexion and in extension. Does it differ? Yeah, you don't have to be so tentative when you examine. So basically, you're looking to see abduction and flexion. So you flex the hip and knee 90 degrees and abduct both of them simultaneously to see what is happening. Then only you can compare between each of them. Yeah. So I think you mentioned most of the things. I'll just hop on a few things which you have missed out. So one is you're not mentioning any special tests. So you've not mentioned about active SLR and telescopy and Narad sign and all those standard tests. It's just for completion. Okay. So you missed out some of those special tests which are required. Then otherwise, I think you have covered almost everything in your examination. I couldn't find anything which is missing. But you mentioned a little bit about the limb length discrepancies. And you said that there is apparent shortening of 1 centimeter and true shortening of 1 centimeter. And when I hear the word apparent shortening, then I want to know what kind of deformity does the child have in the hip.
Sir, since the apparent shortening and true shortening are same,
Then it's worthless. Then it makes no sense.
so the patient has
If the leg is true short, it's going to be apparent short as well. So it makes no logical sense to say that. So remember that when you use the word apparent, it's not an English word. The word apparent is a medical term. It's associated with the word deformity. So the minute you use the word that there's an apparent difference in the limb lengths, it goes along with it equals deformity in the pelvis. Okay? If there is and then there isn't, then it's a true shortening. So the very fact, hi Dalal, come. It's use your logic, no? If there's a limb which is short by 1 centimeter, true, it's going to look short by 1 centimeter as well. So the word apparent does not mean that. The word apparent is a very specific term in orthopedics. It means that there is a deformity. So the minute you use the word apparent shortening or apparent lengthening, the next step is that there's an abduction or an adduction deformity. If there's no deformity, there's no right to use the word apparent length. Then you just have to say there's a true shortening of 1 centimeter, which is then where. So the minute you say that, the next step is where is it? Supratrochanteric, infratrochanteric, tibia. Okay. So
Dr.
please
Taral
remember
Nagara
that.
sir has joined us for the case discussion. Thank you, sir.
Can I just quickly have some rapid fires?
Rapid fire.
Rapid fires on this.
Not us, no?
Not you. if they can't answer, you can answer. We'll pass on to you. Okay. So true shortening 2 centimeters, apparent shortening 4 centimeters. What is the deformity?
Production deformity.
True shortening 3 centimeter, apparent shortening 3 centimeter.
No
With
deformity.
apologies. Okay.
No deformity.
True shortening 2 centimeter, apparent lengthening 2 centimeters.
Abduction, sir, that I have to say because the apparent lengthening as such it is seen in
True shortening 2 centimeter, apparently lengthening 2 centimeters. What deformity? Abduction deformity.
abduction deformity.
Okay.
So I think it's be very careful to use those words apparent. Okay. But otherwise, you mentioned everything fine. Anything was missing?
Yeah, just one.
One that's very important to me is gait, which is for me the first thing that you ever examine. So I dislike when gait is not mentioned somewhere in the case presentation, and especially if it does not come in the beginning, because you're seeing the child walking towards you and walking away from you. It's the first thing before you put the child down on the couch, before they get scared and nervous. Luckily, he's a cooperative boy, but some of them are not. Most children, in fact, will cry. So the first thing is either walking towards you and away from you. First, check gait, because there's so much information you get from gait, which will, make your examination findings also so much easier, and they should all corroborate together. So that's an important lacuna.
Especially in a hip case where Trendelenburg is going to be the best thing, you're going to see the Trendelenburg gait as well. So you must say that. And in general examination, does this guy look tall enough for an 8-year-old boy? So generally you will notice that Perthe is, if you pick that up, it's like a scoring question. That is a slightly short stature. But overall you presented quite well.
Patient has a bipedal.
So about Trendelenburg sign, you said that the pelvis droops on the opposite side, right?
The normal side, when you ask,
The child is standing on the affected leg. The Trendelenburg sign is said to be positive if the pelvis droops on the opposite side. What happens to the trunk? Where is the truncal lean?
on the affected side.
On the
Same
on the side
where
on
he
which
is
the
standing.
child is standing. Why does the child try to lean the trunk on this?
He tries to shift the center of gravity to this side so that less abductive forces.
Yeah. So hip is what type of lever is a hip joint?
First order
Type 1.
type 1.
Yeah. Any examples of type 2 liver in the body?
Sir, and one at the heel. If
Type 3 liver?
Elbow.
When you eat, what liver?
Elbow.
So which is the most efficient and which is the most inefficient lever type?
No scoring question.
Type type 1 liver.
What,
Type 1.
efficient or inefficient?
Efficient.
No.
Type 2 liver.
Type 2
Because
most
since we have a
efficient.
problem standing on the yes.
Type 2 most
2 liver.
efficient. And which is the most inefficient?
Type 1. Type 3.
Type 3.
Okay, again, some rapid fire. Trendelenburg's positive with supratrochanteric shortening. Give one example of this condition.
DDH.
Yes. Trendelenburg negative and supratrochanteric shortening.
So early onset what is initially?
Yeah,
in the case-
trochanteric overgrowth,
Trochanteric.
where actually the neck shaft angle is normal. That can be, Perthe's disease could be an example of that. There is femoral Trendelenburg positive. There is a shortening of the femur and Trendelenburg is negative. Give an example. So this will happen in femoral shortening because of any cause. Okay.
Good. So let's have your diagnosis.
Last question. Tenlelberg positive, but no shortening.
Abductor insufficient paralysis.
Yes.
Yeah. Very good.
Good, he's already scoring. What will you do? Diagnosis and
So my patient, 8-year-old male, is a case of Perthes synovitis secondary to Perthes disease, with a true shortening of 1 centimeter, with a supratrochanteric shortening of 1 centimeter as confirmed on the branch triangle, with a restricted range of abduction and internal and external rotation, with no flexion deformity, with the bilateral femoral pulses palpable, with nil distal neurovascular deficit. Is currently disabled with difficulty in walking and difficulty in sitting cross-legged.
what do you want to do?
I like to take a plain anteroposterior and a frog-leg lateral radiographs.
The screen is there on the right hand side as well for the faculty to view.
This is a plain anteroposterior and a frog-leg lateral radiograph of a skeletally immature child showing both hips with the pelvis and with the open tri-radiate cartilage with open greater trochanteric physis, with the normal right-sided hip with the normal soft tissue, and with the on the left side there is a deformed femoral head with the broadened femoral neck and shortened femoral neck, with the loss of epiphysis of the capital femur epiphysis, with the loss of height of the epiphysis, with the appearance of fissures in the physis, which is suggestive of fragmentation.
Physis cannot fissure. Physis is radiolucent. Yeah.
With the V-shaped translucent cyst along the lateral aspect of the femoral epiphysis, and there appears to be a metaphyseal cyst.
Anyone has a pointer? Laser pointer?
Sir just gave such a brilliant lecture on Perthe. Want to add something more to the lecture?
Yeah.
Ma'am, there appears
Yeah,
to
I
be
think we can show it
extrusion.
on the main screen.
This is stage 2B modified, appears to be stage 2B modified Elizabethtown classification with the cateral grade of more than 50% of loss of epiphyseal height, with the
Don't get nervous. Think shanti say stage of the disease, grade of involvement and
extent. This is appears to be stage 2B modified Elizabethtown on the classification, with the cateral stage of more than 50% loss of epiphyseal height, and
catral has nothing to do with the height. Catral
extension of
herring is the height.
okay. The epiphyseal height seems to be maintained to up to 50%. It looks.
All of you agree with him? Epiphyseal height, is it 50% or less than that? So what herring does it become?
Type herring C.
That's good. I think you have described it well, because very often we find when X-rays come up, everyone starts getting paralyzed. That's the time you should not get paralyzed. Okay. So remember that when you're talking of a joint, there are three parts, the two parts of the joint. There's one bone there and one bone here, and there's joint itself. So you describe all the three. And then basis, physis, and 2 points which we think stand out to us. And that's the biggest mistake you can make in your exam. That's the biggest mistake you can make in practice as well. That if are not methodical in your description of the X-ray, that's it, metaphyseal reaction. Talk of the neck, which is broadened and shorter. Talk of the trochanteric overgrowth. Okay. Then you come to the acetabular side, and there are some acetabular changes also. Then there are some joint changes also. There's so many more things you have still missed. If I have to list out from this X-ray, I would list about 25 points that I can describe on this X-ray. You said about 15. And there are lots of people who will talk of 2. Okay. So it's good what you said, but there's so much more going on in this hip. Right. So all that you described was mainly on the femoral side, which is okay. But there's a lot more going on here. So what you missed out is the joint. You missed out the acetabulum. So that's how I say be methodical when you describe X-rays. Think like a radiologist. Don't think like an orthopedic surgeon, and look at what is most obvious to you. Right. So now, having said that, so you've said epiphysis is collapsed, it's fragmented. You've said that the metaphysis has got a cyst. Metaphyseal, in fact, there's a huge metaphyseal reaction. It's just a single cyst. That whole metaphyseal is a metaphyseal reaction. There's a cystic reaction to metaphysis. You did not say that the neck is broad and short. You did? Okay. The trochanter is a little high riding. So that finishes the proximal femur as far as the description of that is concerned. Then, on the joint side,
acetabulum appears to be
on the joint. So there's a joint is between 2 bones. So on the joint side, is there a widening?
Yes.
Is there a difference between the teardrop and the medial metaphysis on the left side compared to the right side? Yeah, correct. Is there extrusion?
Yes, there is some extrusion.
Well, not what I can see from here, because it looks well within that Perkins line, but definitely there's a widening of that epiphysis, a widening of the joint space. And the reason why it's not showing so much extrusion is because the acetabulum also has changed its shape. So don't forget that in Perthe, the acetabulum also does change shapes. So what do you see in the acetabulum?
The acetabulum appears to be deformed with the hazy borders.
It looks a little larger than the other side as well. Do you feel that there is something which is happening in the pelvis? Because if you look at the operator foramen, you see the ischial spine. It's not symmetrical. So these are all subtle signs which tell you that there is some restriction of range of motion. Because when you try and frog like that child, you can see what is happening again on the frog leg lateral X-ray. So all the subtle signs that there's a restriction of range of motion because it's not going to the full range. So when they're trying to move the hip, the pelvis is in fact moving because of that asymmetric ischial spine. So that's an ischial spine sign, and that's the operator sign, which is positive. So there's so many things on this X-ray which are going on.
What about tilt of the pelvis? Is it forward tilted or backward? Can you know from the X-ray?
Is it like an inlet view, an outlet view? So
seems to be an inlet.
So there's a little bit of it. So then I would go back. Examine the child again, and I have a feeling this child may have a never described to us, because when I look at this, so these are just the morphological changes, and then because it's Perthe, then we go into that extra stuff where we talk of what is the stage, what is the grade, and all the sort of things. So there's so much going on X-rays that we must understand, and that's why I keep telling all of you all, sit together, pick X-rays up, and start discussing them, because that's the sort of the watershed we have seen when cases are there. That you present well, your clinical examination is fine, and then when it comes to the juice of the matter, where we really want to look at decision-making process, we want to see your skills in that. That's when you'll get paralyzed. And that should not happen, because the X-ray is the stepping stone to go further. If you'll stop on that and say, I see collapse, that's not an answer at all. We can't proceed anything further with that sort of a description. Okay. So pick X-rays together, discuss with each other. That's the best way to learn how to describe X-rays in entirety the way we have described it. Yeah.
So one more thing I wanted to add to this thing is symptoms may vary, signs will never differ. They'll be fixed. So if you made a mistake in saying that there's no FFD, and then the examiner sees this X-ray and your marks go down or you fail, then you have only yourself to blame. So double check everything, and before you start presenting, write it down and see whether it's matching. There are examiners who try to tell you, okay, predict the X-ray, and then they put it up based on your findings. So it must match. So clinico-radiological correlation, very important.
What will you do?
Sir, I'd like to, since the range of motions are restricted, I'd like to improve the range of motion by doing physiotherapy and asking the patient to avoid all the contact sports activities like jumping, running. And once the range of motion improves, then I'll think upon the.
Just that, or what does it match your clinical stage? Is this what you expect in a 2 week?
No, the symptoms.
What do you do?
But symptoms will be a bit more because he might experience pain also occasionally. Here,
But he said that he does. Some children are tolerant. Pain is a very subjective. So will you just ask him to restrict, or would you like to do something else?
then go for a containment procedure since.
So why jump to that? Up to now, you're doing fine. Just relax. Don't be nervous and think logically. If a child is not relieved with just telling him not to, which child is really going to listen to don't play sports in a vacation? How will you ensure that he doesn't play sports?
I would maybe put him in a Petri cast, maybe to
Before that, what will you do?
traction.
Admit the child, put him on NSAIDs, give him traction, make sure that does traction really do anything by pulling the hip down?
It maintains the length of the muscle also and prevents any.
It simply ensures that the child stays in bed.
What are causes for restriction of range of movement in a case of prosthesis?
Alteration in the shape, femoral head and acetabular shape, which
What else? Again, think logically. The causes could be in soft tissues,
muscle.
capsules.
You should go by the stage of the disease, because in different stages, different causes for the pain.
Yeah.
So when you have change in shape of the head and the acetabulum causing pain is like when you're 40 years. It's not going to happen in an 8-year-old child. So in a 7, 8-year-old child, in the early stage of the disease, what's the commonest cause of pain? Synovitis, absolutely. What causes that synovitis?
Inflammatory reaction.
Okay, and sometimes a subchondral fracture. So that's another important cause, because sometimes they're acutely painful with a subchondral fracture. So a subchondral fracture, so a child comes with a lot of pain, acute pain. A subchondral fracture is sometimes a cause for it. Synovitis, definitely, because of both mechanical and inflammatory causes for it. Then what else? Other causes? Muscle spasm itself causes because beyond a point, muscle spasm stops being protective and becomes useless and then becomes painful. So muscle spasm itself is a protective sign, but also can cause pain.
Hinged abduction.
Huh?
Hinged abduction.
Hinge abduction is very rarely painful as such, because that is a change in the shape of the head. It's very rarely painful. But these are the commonest signs, especially a young child. So you said change in shape of the head and the acetabulum is a much later thing. In fact, the commonest thing in a young child like this is synovitis, subchondral fracture, muscle spasms. Are the three more. That's what the reason we want to do all these things. That's why our treatment is geared towards that. NSAIDs for the inflammation, traction for the muscle spasm, and rest for the synovitis. So that answers why we do these kind of conservative treatments. And then the others subside with that, and the hip is still inflamed, and the still is not regaining range of motion over a period of at least 7 or 10 days, because you don't give it for longer than that. Then you start thinking in terms of Petri cast and other things to restore his abduction range.
Okay,
So I think
thank
that
you,
was
Dr.
a
Vasu.
great present. I think we must really applaud him because he's answered really well. But it's not. It's quite tough. When you actually stand in front of examiners, unless you're really well prepared, it's difficult at times. Yeah. And the key thing is to keep your nerves and to answer whatever you can. If you don't know the answer, just say I don't know, rather than just digging a hole deeper and deeper.
Does anybody have any questions or doubts regarding the case or Perthe's? So we can just clear them before we move on to the next case.
That's a huge ask.
Whole world is still doubtful. So there is nobody who doesn't have a doubt about it.
Now, even when it comes to this child about whether containment would help or not, it's a variable thing, because now it's that watershed area. If it was very clearly 1A, 1B and early 2A, it's still easy to make that decision. But once you go into 2B, there are some who would say, yes, I would always contain. There are some who say, no, I don't want to contain. That is also variable. So you stand by whatever you think and stick with it.
So in cases of before 2A, before the stage of 2A, during that time, what is the role of, if we are going for containment, is there any, what is the role of braces? Means that Atlanta brace and Scottish Rite scars or a broomstick, do we go for that first or do we go for surgery? For
How many of these braces have you seen?
Yeah, so
How many have you seen?
I have not seen, and even in your presentation, I did not see. So
Neither have we in practice.
Okay.
See, because
So
you
in
understand
practice,
that-
we go for a surgical containment
No,
rather
you say
than for
brace,
some brace,
you're
something
mixing up
abrasive.
Petri with other braces. Petri is not a brace. Petri is a different thing altogether. That's for improving the range of motion. Braces are like the Newington, Atlanta, Scottish Rite, and all the different types of braces. They are a form of containment procedures. Instead of surgery, you can contain the hip with these braces. The question is, if you have to do that, you have to remember that you want to contain that hip in that brace throughout the period when the hip is likely to extrude, which is the stage of avascularity and the stage of fragmentation, which is like 2 years. So are you going to have the child in a brace for 2 years? Are they going to ambulate in that brace for 2 years? So it's just not practical. Does it work? People who have used the braces are very happy with it. Centers have used the braces because they've been able to ensure compliancy and adherence to that bracing. But if you're not able to ensure that, and we all know practically which child is going to wear a brace for 2 years, you tell someone to wear for 6 days of 6 months, so it's understandable. Beyond that, no one is going to wear. So for that practical reason, we hardly ever talk of conservative bracing as a form of containment procedures.
So in bracing, you're leaving everything to the parents and the child, right? You're going to have a brace going from the hip up to the ankle with no knee bending allowed. So that's going to be very tough. So that's why none of us have really actually seen it in practice. But a Petri cast is under your control. You are doing it under anesthesia. You're actually placing that hip in the amount of abduction and internal rotation that you want. And it's a temporary thing. So all of us know that you can easily control that. That can be done till everything subsides and then you start ranging them.
So if this exam was taking place in Japan, in Tokyo, at some institution, the answer would be admit the child for institutionalized bracing and conservative.
Okay.
So Perthes, they are admitted in a hospital for 6 months, 9 months, 2 years, till the time the disease is controlled. And schooling, sports, therapy, everything happens in the hospital. So that's the treatment which they still follow.
Yeah. No, because as students, we see in Pakistan, we see those images of Scottish Rite brace, the child is playing upside down and everything. So that is why that's something that probably
I'm in our country, I've so
Yes.
far seen only one person using it, and that too somewhere in the remote village.
Okay. Okay.
The Texas Scottish Rite brace is not even used now in that same hospital.
Okay.
Okay. Okay. Thank you. Thank you. So we'll proceed to the next case. It is going to be presented by Neeraj Kalra. It's a short case.